Welcome, everybody. So my presentation is going to be a little shorter and a little simpler because surgeons sometimes tend to be simple people. We're not as smart as anesthesiologists and internists, but hopefully we'll get you out of here right on time. So I definitely want to thank Dr. Chapa for the kind introduction, and I also want you to know that we are very, very lucky to have Dr. Shander here. Dr. Shander is basically the poster child, the superhero, and the godfather worldwide of patient blood management. And he travels all over the world to come to Prescott. I appreciate it. Thank you very much, Dr. Shander. So I was asked to talk about informed consent. I've never given this talk, a talk on this topic before. So I started thinking back to when I was a small child. I was about 8 or 9 years old, and this little girl next door, Susie Kapul, asked me if I wanted to play doctor. And I said, being a little sheltered, well, how do you play? And she says, it's easy. Before I do something to you, I have to ask you if it's okay, and you have to agree. And before you do something to me, you have to ask if it's okay and agree. And after our play session, that's when I knew I wanted to be a doctor. But seriously, this illustrates the very basic right of an individual. The right to determine what, why, how, and to what end something is done by one individual to another individual. So what's the legal definition of informed consent? It's a decision to undergo or not undergo a medical treatment, such as a transfusion or any other medical treatment, after receiving adequate disclosure of relevant information. So what is adequate? What is relevant? I can tell you that in treating tens of thousands of patients, that what is adequate to one patient may be totally inadequate to another patient. The Joint Commission, TJC, is a regulatory body that instructs, audits, and credentials hospitals. And they have given us some guidelines as far as to what informed consent comprises of. Informed consent, obviously, you have to talk to the patient and identify the diagnosis, tell them what you're going to do, what kind of intervention, what kind of procedure. You have to disclose what the risks and benefits and side effects of these procedures are. You have to estimate the likelihood of achieving the desired result, as well as the alternatives, as what are the risks, benefits, and side effects related to the alternatives. So if you bear with me for a minute and a half, and I'm going to apologize to this young lady right now for doing what I'm going to do. I'm going to give you what my canned speech is if you're coming for open heart surgery. So I will come into the room and I'll say, hello, my name is Dr. Tibi, and your cardiologist asked me to see you and talk to you about heart surgery. As you know, you have blockages in your arteries, and we are recommending bypass. The way it will work is that we take you to the operating room, you'll meet the anesthesiologist, he'll talk to you about the anesthesia, he'll put you to sleep, and you won't feel anything. Once you're asleep, we make an incision from here to here. We put you on a bypass machine that takes over the function of your heart and lungs so that we can work on the heart. My assistant will take vein from your leg through a small incision using a scope that we will use to bypass the blocked arteries of your heart. Once we are done, we wean you off the cardiopulmonary bypass machine, close things up, bring you to the intensive care unit, and where you will still be under anesthesia, and once you're able to come off the breathing machine, we take you off the ventilator. As soon as I'm done, I'll go talk to your family in person and let them know how you're doing. Shortly after you wake up, we will get your breathing tube out as long as your lungs and hearts are strong enough to come off the breathing machine. Most people spend 2 days in the ICU and another 3 to 4 days in the step-down unit before you leave the hospital. It takes 3 to 4 weeks before you start to feel back to normal, and about 12 weeks before the bone to heal so that all the restrictions are lifted. Obviously, this is a big operation. There are risks of bleeding, infection, the risk of anesthesia, the risk of blood transfusion with its attendant risk, heart, lung, kidney failure, stroke, and death. Taking Taking everything into consideration, I would estimate that the risks for you are around 2-5%, whatever they be. The alternatives to surgery are stents, medical treatment, but if we thought they were a viable alternative, I wouldn't be here talking to you. That usually answers most people's questions, but if you or your family have any further questions, please feel free to ask me now. Now, that took about a minute and a half, but I'm a caring surgeon. I usually take about 3 or 4 minutes. So, would you agree? I'm sorry. So, would you? Did she say something? So, so would you agree that what you've heard was pretty comprehensive and you've heard most of what I talked about in that first slide? Raise your hand. Okay, well, those who have raised their hand have now agreed to heart surgery, so I'll take your names and we'll take you in tomorrow. So, once again, joking aside, we take a patient and we've pretty much comprehensively given them what we've been informed by the Joint Commission to give them for an informed consent. We've given them the viable options. I've given them the risks of surgery. I've given them what can happen after surgery, et cetera, et cetera. But as you can imagine, for something as complicated as heart surgery, there's so much more to know. How much does the patient have to? How much does the patient want to know? So most patients will then go to the computer and Google coronary bypass surgery, and usually you come up with Wikipedia. And when you look at coronary bypass surgery and you look at Wikipedia, there's a ton more of information with more links to go to more places to learn more about cardiopulmonary bypass surgery. As well, if you look up atherosclerosis, once again, there's a ton of information with more links to go to more places. And God forbid you look up the bypass machine. Talk about the eye test. God forbid you look up bypass machine. There's a tremendous amount of information. So what, as a physician, is really fully informed consent? In addition to that, in addition to all that I have to talk to the patients about, there are other difficulties in obtaining informed consent. There's a patient's ability to understand. There's a vast array of ability of comprehension depending on the patient's education, depending if there's any minor or major language barrier, depending on how the procedure is explained and lack or thereof of lay terminology, as well as the overall sophistication of the patient. The depth of the explanation needed. I can tell you that so many times. I will start in that 3 or 4 minute canned talk that I just gave you, and the patient will interrupt me and say, "Doc, I don't want to know all the gory details. Just do whatever you have to do. I trust you." There's a degree of stress of the situation. Imagine a gentleman is in his living room having a cocktail, watching TV. He gets a little chest pain. His wife makes him go to the hospital. And within 3 hours, I'm standing over him saying that I'm going to crack open his chest and there's a possibility he might die. There's a degree of duress due to the presence of others. With other people, whether it be doctors or nurses, families, friends, even clergymen, they may be there, that are telling a patient, you have to do this, and telling the patient, this is the way you have to do this. There's a lack of non-biased information. For example, you can't go to Consumer Reports, and please do not go to Angie on Angie's list. You're not going to find the information lacked of bias that you need. And then again, there's perception versus reality. What is the reality? What is the perception? Because we don't really know. We can't predict the future. All we can do is share our knowledge with the patient about what we think will happen. Because one person's perception and another's may be completely different. And we all know how detrimental faulty perception can be. So what where did informed consent start? Well, back in the early 1900s, a patient, Mary Schoellendorf, who was an elocutionist, not an executionist. I had to look up elocutionist. An elocutionist is someone who teaches people how to speak publicly, which obviously I could use. Anyway, she was admitted to New York Hospital to evaluate for a stomach disorder. And she was examined by a house physician, and that house physician, probably through palpation, felt a fibroid. And he suggested having that fibroid surgically removed. She adamantly denied to have that removed, but she did agree to have an examination under anesthesia. Well, for whatever reason, they did the anesthesia. Maybe for whatever reason, maybe it was very easy to take out. Maybe it fell out. Who knows? But she had, that fibroid was removed. Unfortunately, after surgery, she had some complications. She had gangrene of the left arm and she lost some fingers. Probably had nothing to do with the actual removal of the fibroid. Nevertheless, she blamed the surgery and took it to court and filed suit. Well, the court found that the operation to which the patient did not consent consisted medical battery. That every human being of adult years and sound mind has a right to determine what shall be done to his own body. Another case in the 1960s, and actually brought to court in the 70s, was a patient named Cobb who went to a Dr. Grant in California. Mr. Cobb had ulcers, and Dr. Grant consented him for an operation to take care of his ulcers. He went to surgery, he had the operation. Once again, unfortunately, he had some complications. There was laceration of the spleen, there was recurrence of the duodenal ulcers, and that patient sued, saying that he was not informed of the possible complications of that operation, and won. The court decided as an integral part of the physician's overall obligation to the patient that there is a duty of reasonable disclosure of the available choices with respect to proposed therapy and of the dangers inherently and potentially involved in each. So let's talk a little about semantics here. So we're working it from the back here. Avoid problems with this. So anyway, let's talk a little about semantics. Informed consent. Informed consent basically shows two options. One is to agree to consent, which is commonly understood. The second one is to not accept, to decline or refuse. Now, decline can connote something like rejecting politely or courteously, such as declining a dinner invitation. Whereas refuse emphasizes firmness, or rudeness, such as refusing to obey an order, or in our realm, going against medical advice. Ooh, yeah. That's what consent means, or declination of consent. So, should we call it consent choice, or informed choice, as opposed to informed consent? Because, like I said, consent implies that there is no choice or real option, whereas choice conveys the possibility of several options, and it allows the patient to make a decision freely, under no duress. So, what else do we have to guide us? Well, we have the Hippocratic Oath. It's an oath that physicians take. I don't remember taking this oath, but when I looked it up, it was pretty impressive. And there's a new one and the old one, and this is the old one. And it says, I swear by Apollo, physician, by Asclepius, by health, by Panacea, and by all the gods and goddesses, the old gods and the new gods, the Lord of the light and the Lord of the darkness. That's from Game of Thrones. Come on, guys. Anyway, it says that I shall never administer a poison to a patient. But we do that every day. We give blood thinners, Coumadin, commonly known as rat poison. We give chemotherapeutic drugs. That's their job, is to kill cells. It's a poisoner of cells, and we hope it goes to the right ones. But we give blood. And blood, as you've heard tonight, can be a poison. So using that Hippocratic oath, that doesn't really help us all that much because blood can actually do some good in hemodynamically unstable hemorrhaging patients. So what else do we have to go on? Well, there's the fundamental principles of medical ethics. The first one, obviously, is beneficence. Do good. Heal the patient. That's obvious. The corollary is non-maleficence. Doing no harm. Primum non nocere. The third one, justice. Treating a patient or giving the patient fair and proper respect for human rights. The fourth one, autonomy. Allowing the right of the individual to self-determination. And the last one, veracity, truth-telling. The whole truth and nothing but the truth. But medicine and surgery is not a science. And once again, like I said, we cannot predict the future. Therefore, are we telling the truth? Well, for 60 years, from 1940 to the 2000s, and even in some places today, people are transfusing patients to a hematocrit or hemoglobin of 10 grams per deciliter. That was published in an article in the 1940s by a Dr. Lundy with absolutely no scientific proof that that is where we used to go, where we need to be. And for my entire career in medical school, in residency, and some of my career even as an attending physician, I was going on stuff that was going from the 1940s. So, veracity, truth-telling, if we can. So the government, where else can we go? The government gives us guidelines. Guidelines that the patient can make the right decision about care, and the physician has to inform the patient of the health status, etc., involved in the care, planning, treatment, and be able to request or refuse treatments. It further says that hospitals must develop a process so that physicians will follow these rules and their policies and procedures to protect the patient. Furthermore, it says that the hospital has to have a document that is well designed to obtain consent from a patient. And this document must be placed in the medical record. And their disclosures that statement that the procedure or treatment, including the anticipated benefits, material risks, and alternative therapies, was explained to the patient. What are material risks? Which material risks? All of them? None of them? Well, it says material risks can include risks that have a high degree of likelihood but a low degree of severity, or a low degree of likelihood but a high degree of severity. So there's words like likelihood, more, less, severe, not so severe. There's so much subjectivity in that there's just absolutely no way to make sure that we're doing our job in informing the patient correctly. The Joint Commission adds that the hospitals must have policies for the physicians to follow. It must tell you what procedures are needed for informed consent, that the process in which the consent is to be obtained, and how the informed consent is to be documented in the medical record. So how do we do as physicians for blood transfusions? So when a patient is admitted to the hospital, they sign basically a overall consent. They sign for minor things like IVs, like a Foley catheter, for like a nasogastric tube, and you can see that consent is not really a specific consent for those procedures is not obtained. Obviously, for something like a heart operation, you would want a specific consent for that procedure because of all of the possible problems that might happen and everything else that goes into it. But where does blood transfusion lie? I say, and I think most everybody in medicine says, that blood transfusion needs its own specific consent that will talk about the specific risks of that transfusion, whether the physicians know it or not. Now, we do pretty well here, and I would claim to say, even though it's 70 to 90%, I would claim to say it's probably close to 100% because, as you can imagine, probably 20 to 30% of blood transfusions are given in a very emergent fashion to hemorrhagic patients who cannot sign consent. Okay, so we do obtain blood consent in almost all patients, if not all. How are patients doing? Well, this was a very interesting study that looked at what patients recalled about receiving transfusions. So what they did is that they documented verbal informed consent to the patient about blood transfusions. They talked to them about the possible risks. They talked to them about the alternatives. And they even gave them a pamphlet that was entitled, "You May Need a Blood Transfusion," to every single patient, 344 patients. Well, after the patients were discharged from the hospital, they queried the patients on what they remembered about the blood consent. One of the first questions is, do you remember getting the pamphlet? Only 41 patients out of 344 remembered about the pamphlet that they received. To be honest, they probably got a half a book of information too, and it's just easy to glance over some of these things. But 280 patients didn't even recall, denied, or didn't even answer the question. When they were asked about specific transfusion risks, such as hepatitis, bacterial contaminations, or getting the wrong units, only 25% of patients recalled that they were warned or consented knowing about the risks of transfusions with these particular things, these particular conditions. And many of patients still didn't answer. And when asked about alternatives for blood, a whopping 88% said no, can't recall, or didn't answer. So I think this could be the definition of obliviousness. So in essence, what we have when it comes to informed consent in transfusions is that physicians may not know, believe, or express the risk of transfusions appropriately. And we may have patients that do not hear, remember, or care about transfusions, which unfortunately breeds a very, very fragile patient-doctor relationship. I had to look at this slide carefully. These are women, whoops. Yeah, these are women pointing. Okay, these are women pointing a gun at you, and you think they're winking at you. Okay, let's go to that one. Great. So, what are common reactions to patients who choose not to accept an offered treatment? Well, there could be a loss of comfort and confidence by patient and medical staff. The patient saying, "My doctor doesn't like me because I'm not agreeing." The doctor says, "My patient is being difficult, he's making his job harder, he's making me work with one hand tied behind my back." There may be feelings of distrust between the patient and the medical staff, and trust is the most important relationship between a physician and their patient. There may be relinquishment of the outcome responsibility by the staff. The nurses or doctors saying, "Well, if he's not going to do what he says, what we say, well then whatever happens to him is his own fault." There may be a rise in fear of the uncertain in the patient. I mean, a patient going against or choosing something that the physician has not ordered can get all kinds of second thoughts about whether he's doing the right thing. And there could be introduction of discord in the patient's family and the staff. Why are you being so hard-headed? Why are you not listening to the doctor? Why are you being a difficult patient?
The doctor will be with you in a moment. Difficult?
Elaine, you shouldn't be reading that. Now tell me about this rash of yours.
Well, it's, you know, I I noticed that someone wrote in my chart that I was difficult in January of '92, and I have to tell you, I remember that appointment exactly. You see, this nurse had asked me to put a gown on, but it was a mole on my shoulder, and actually I'd specifically worn a tank top so that I wouldn't have to put a gown on. You know, they're made of paper.
Well, that was a long time ago. How about if I just erase it? Now, about that rash.
But it was in pen. You fake erase.
All right, Miss Venus. This doesn't look too serious. You should be fine.
What are you writing?
You saw the breakdown of the doctor-patient relationship there? So let me quickly tell you my story, because it really is a story of dumb luck. I came to Phoenix in 1989, and I was approached by a patient, a Jehovah Witness, who would not accept blood. And they came to me and they said, "Doc, I've been to 4 or 5 heart surgeons, and they say if you won't do what I tell you to do, then I'm not going to operate on you. Will you operate on me, please, please, please?" And I said, "Sure." And you might think it was compassion or humanitarian reasons. I needed the work. So I operated on this patient, and then I started getting more and more patients that would not accept blood. And over the ensuing 5 years, I probably had about 100 patients. And it came to me, slowly, but it came to me that my patients that were not getting blood were doing better than my patients that were getting blood. And how could that be? Because blood saves lives. And right around that time, there started to have more and more literature saying that blood may not be all that it's cracked up to be. And in looking at my patients carefully, I found the same thing. So that was how I got into patient blood management. And over the last 10, 15 years, there's just been an avalanche of literature that shows, like Dr. Shander showed, that this is, if you can take care of a patient through patient blood management, and at the very least decrease the amount of blood that may need, then your patients will do better. Just so you know, Jehovah Witnesses are allowed to receive some things are permissible, some things are not, and some things fall in what we call a matter of conscience. And I depend and I receive a lot of assistance from someone like Mr. Black to help each and every individual to make these decisions, and for that I'm grateful. So when a patient chooses not to accept blood, what do? Well, lose less blood, stuff that I thought of, 20 years ago. Well, if I don't lose a lot of blood, maybe I can get them through, duh. But really, it requires a full treatment plan. And with open heart surgery, and most every type of surgery, it's a multimodality therapy. The things in yellow are things that are specific to cardiac surgery, but the things that are not are applicable to many types of surgeries as well as medical therapies. So you can see that all these things together is what makes up patient blood management program. So real quick, I'm going to go over a case, and this is not hypothetical. This is a real patient. It's not a patient from here. It's not a patient that I operated on. But let me nevertheless go through it. And pay attention here, because I'm going to ask you to answer a question. I want to see everybody's hand go up for one of the 3 answers. So 42-year-old healthy Jehovah Witness male was admitted for a mitral valve replacement. That's where we replace a valve. The preoperative discussion with the family was held with a patient, with a family, with a minister, with the patient alone secluded so that there's no duress or expectation on anyone else. And a very in-depth conversation was made in discussion about blood management, and the patient does not want to receive blood under any circumstance. Preoperative preparation, the multimodality therapy was followed to the T. The patient was taken to surgery, and he had a mitral valve replacement, which occurred without incident. But unfortunately, as the patient was coming off of the heart-lung machine, the surgeon noted a fair amount of blood coming from the back. And what that is called an atrioventricular disruption. That's when the chambers of the heart separate, and it's almost always fatal. And I would say, nearly 100% fatal if you don't have the option of giving blood. The surgeon placed the patient back on bypass, and this is where I'm going to ask you. You've got three choices. You're the surgeon. We're going to play surgeon. Everybody here is a heart surgeon. The options are continue with surgery without blood, even though it appears that the patient will expire. Continue with surgery and give blood because it's the humanitarian thing to do, because you've taken that Hippocratic oath, because it's the right thing to do, or it's God's will, and surgeons often confuse God's will with the surgeon's will. Or, while the patient is safe back on bypass, go out and talk to the family. Who votes for A? Who votes for B? Who votes for C? Okay. The surgeon goes and talks to the family and states that the patient will not survive without transfusion. The wife, who has medical power of attorney, asks the surgeon to do whatever is necessary to save her husband's life, even if blood is required. Let me tell you that you all answered that question better than any medical presentation where there are physicians and nurses that I have seen. The correct answer is A. The patient has made his decision. He was properly instructed. No one can change a patient's wishes. John Stuart Mills was a philosopher in 1859, and he published a very popular philosophical manuscript called On Liberty. Everybody that is admitted to Parliament today gets a copy of this. And it says about liberty that the only purpose for which power can be rightfully exercised over any member of the civilized community against his will is to prevent harm to others. His own good, either physical or moral, is not sufficient warrant. Over himself, over his body and mind, the individual is sovereign. In summary, we've discussed the ethical principles that support the concept of balancing the true medical need with a patient's preference. And the challenge to medical practitioners is to understand the true medical need for transfusion. And alternative strategies to the use of stored blood are available and should be used whenever possible. So before you make a choice, make sure it's one that you can live with. Now, in ending this, first of all, I want to thank you all. It's such, whoops, there goes that pointer. It's a good thing it's over. So first of all, I want to say, to see such an audience in a medical talk, more or less, it warms my heart. It shows that this community is involved in its health care, and that makes for a concerted and excellent healthcare association between the community, the physicians, the hospital. Obviously, I want to thank the audience for being here. I also want to thank the audience that is watching this streaming. Could be anywhere in the world, and that's really exciting. I want to thank Dr. Chapa and Dr. Shander. And you know what? The hospital here puts this on their dime with the help. I mean, Dale runs it, and to find an administration that's willing to shell out money to do this and so forth for the community, I think is really special. And there are so many people, too, that are running the show and behind stage and that do a bang-up job. So I want to thank them as well. That concludes our program. And please enjoy yourself. Have a safe drive home. And drink plenty of vinegar. Balsamic vinegar is very high in iron, which will keep your blood cell count up.